Hello, everyone. I'm Maya with Trials with Maya Z, and I'm here today with Estelle Jobson, a patient advocate that I met a few months ago. She was on stage on one of the top patient engagement events, at least in Europe. Um, a patient fellow, like very much associated with EUPATI, and trying to bring her expertise and her experience towards helping others. One thing that was very, I would say, exciting to me is when I met Estelle was how well she communicates the problems of patients. And one thing that like the other thing that really excited me before inviting Estelle to join me in a mini conversation on my podcast was the passion that she has for women's health, and most specifically fighting endometriosis, a disease that I know for many friends and many people in general is like very serious and sometimes under researched. Estelle, thank you so much. Welcome to Trials with Maya Z. And if you want, you can share a few words about your background first.
Hmm. Thanks for having me, Maya. I'm happy to be here today. Um, yes, I mean, you summed me up nicely. I'm a patient advocate. My disease is endometriosis, and I'm trained by EUPATI, the European Patients Academy. And I like to call myself or us patient advocates a tinker, which means we kind of go up and uphill, down dale. We meet people along the way, we share our expertise, and we learn as we go. And it's not a very clear path ever, but
Mm.
we keep going and meeting interesting people. Like we met, so I'm really happy to share some of my knowledge about endometriosis and the situation in research and trials for this disease area.
Thank you, Estelle. Let's first start with women's health in general. You actually, when we met last time, you mentioned some really shocking percentages for how much funding is being spent on women's health research. So can you just share that with my audience?
Yeah, it's quite shocking, as you say. I mean, I've got two statistics. The one is that closing the gender health gap starts with investing in research on the female body, yet only 4% of healthcare R&D spending in the US goes towards women's health. That's one statistic, 4%. And the other one is that only 1% of global healthcare R&D
Wow.
and innovation goes to female specific conditions beyond cancer. So we're somewhere between 1 and 4%, which is pretty dismal given that we are also 51% of the population, and we earn 40% of GDP,
Yeah.
which is interesting. Yeah,
Interesting perspective that you mentioned the GDP, but yes, makes sense. Like, let's say that we're a good market. Like, but
we
Estelle,
would say.
why do you think this is the case? Like, what's your, how do you explain that to yourself?
I mean, this is a sad state of affairs. I think it taps into quite topical matters that you're reading more and more about the gaslighting, medical gaslighting that women are subjected to. That when we come with symptoms, we're told, "Oh, you're just anxious," and put up with it. There's nothing wrong with you. We're patronized in that way. I think a lot of it also goes back to the general gender bias in medicine's R&D, such as, I mean, right from in the lab where they're working on the male mouse because they don't want hormones, interrupting the R&D process. The whole process has a male bias in terms of the male cells, the male mice, the male trial participants.
Mm,
Okay, obviously, when they're testing a drug for a woman's disease, the participants will be women, assigned female at birth. I'm going to try to get my language right. But it's really, I think, just the whole area of R&D is has suffers from a male bias.
mm. I
Yeah.
guess you were more complicated. You're absolutely to the point when saying this with the hormones. I had the again another like interview with the Parkinson's disease patient advocate, and
Yeah.
she's actually in like research. Both her her husband and her mom died of Parkinson's, unfortunately. And she said it's just super more complicated, like because she saw her mom and also her husband, male and female, going through the same disease. And she was like, well, with women, it is different. Actually, she gave me some ridiculous numbers on misdiagnosed and underdiagnosed like women patients, just because exactly what you said. The first thing is that, oh, she has her period, or like for whatever reason, sometimes this is really a big burden, like burden, and
Mm.
also a barrier for even diagnosis, not only treatment.
Yeah.
So, what about endometriosis still? Like, what is the status of endometriosis today? How much is being researched, and is there like a established standard of care for this disease?
We do have a pretty long diagnosis, somewhere between 6 and 12 years, is the typically cited figure. It seems to be dropping with public awareness, so that is good news.
Yeah,
And more women are kind of self-diagnosing with information and going to healthcare professionals saying, I think I have this. And so that's helping us. We're helping ourselves.
yeah,
Um, so that's the one thing, the diagnosis, but that's the same as if you have a rare disease, which I mean, endometriosis is not a rare disease, so we shouldn't have such a long time to diagnosis. So that's the one point. What what is in terms of standard of care for endometriosis? The kind of typical things are painkillers, oral contraception, hormones, which is typically estrogen suppression, GnRH agonists and antagonists. Ultimately, some kind of weaker or stronger form of induced menopause. So that's our standard of care, and surgery. Surgery
hmm,
is a very important one because it can be done very well or very badly. But I want to just read in terms of standard of care. I want to read a little quote I got from a woman on a online I was going to say online support group,
hmm,
and she has had the standard of care. And she's in quite a good position because she has a job, she has private healthcare, she has a husband she likes, and she has achieved she has achieved her fertility goals. So let's listen to what she says. And her pain is kind of under control.
okay,
But let's listen. She says, any ladies out there who have had 10 laparoscopies, one ablation, because we get tired, then find precancerous cells on the cervix, but ding, 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 and more endo. So I got a hysterectomy. Let's move on. It's been 2 years. In these 2 years, I already went for intestinal endometriosis surgery. Is there anyone to talk to? It's back, obviously. But I just started a job because my husband and kids need two incomes. And when the new year strikes and medical aid is regenerated, I can get help. But what now? I just had that pain that feels like you're literally giving birth, and I'm crying. I've been handling pain well, but is there a friend in my shoes? Whom can I talk to? I'm on sleeping aids and anxiety meds because I can't sleep, not just because of the pain, literally everything. My feelings, my hormones, my anxiety and depression. I don't know. Any friend out there? Listen, please don't recommend hormones. It has done enough to my marriage and I'm done. I'm scared.
mm,
I sound terrible. I'm crying so much I can't even type properly. So this is very moving, but it's not entirely uncommon. And this
mm,
is a woman who's had standard of care. So clearly, standard of care is not hitting the spot for us. So,
yeah.
what I call for is researchers to put aside these quite traditional views on endometriosis, on what the disease is, on how it works, and to come with fresh eyes, to think out of the box, to explore new ideas, and to come to the patient community also to look for clues as to what those may be. There
Mm.
is more and more in research on endometriosis, but we still like this is still the reality, the standard of care for
But
us.
like, why isn't there progress if there is research on endometriosis, and if, from what I see, standard of care is not something that is like solving the main issues for women? Why don't we have something better? Like, what stops this progress?
Part of the problem, I think, with endometriosis is the disease definition, that
Mm.
it is obsolete and it is incorrect.
Okay.
And it is repeated over and over again. It's almost like, it's like fake news. You read it, you read it, you read it, you cite it, you cite it, you cite it, but it's still wrong. It's always wrong. Um, and this prevailing definition focuses very much on the symptom of pain with menstruation, and this link, which is fallacious, is to the endometrial tissue. Endometriosis is not endometrial tissue. The name in itself is even wrong.
Mm.
So we're so kind of blinded by this wrong definition, by this wrong name, and the public awareness attaches to this wrong definition. So I think that's part of it, that people keep coming back to endometriosis as a menstruation uterus related disease, which it's not. It's a systemic, body-wise, inflammatory chronic condition. And I think it would help researchers to really look at it with fresh eyes, and to ask patients as well. We always say that, ask us what our questions are, because our questions will take you to quite interesting suggestions.
Interesting. Actually, our since standard of care is not that attractive, let's put it that way. Um, are patients with endometriosis interested in clinical trials? Like, do they find them as a good option, alternative?
Yes, look, there are a lot of women with endometriosis who cannot get specialist care, so
Okay.
they're pretty desperate because there are so few specialists in the world. I mean, there's
Mm.
literally like a few hundred
Oh
global,
wow.
like globally. Um, Poor women in poorly resourced settings, they can't get that. So I would say for them, trials could be an option. But we are also skeptical of trials that are just sort of recycling some version of induced menopause. And we are also deeply skeptical of new treatments that are basically recycled treatments.
Mm.
And that you will see in the online support groups, that the members are saying, hey, watch out, this is the same old thing, we've seen this before, it's just got a new name and a fancy new
Oh wow.
packaging. Yeah, so trials could be useful, but we don't want to see the same old, and we need the outcomes of the trials also to be different. Yeah,
So tell me
it's
more.
lots of work.
Like, what type of outcomes do you actually expect?
uh
Like, what are the outcomes that are being traditionally expected, and how they differentiate from the outcomes that, let's say, an endometriosis patient would expect?
okay. um as a precursor to this answer, I would like to say, yeah, the prevailing symptom of endometriosis is pain, not always, but often. And the pain, it's very debilitating. It's very all consuming. I like to say it's like
Mm.
having a siren in your ear. If you have this pain all the time, you're kind of, it's like you can't hear anything else. You can't see anything else. If you can switch it off somehow, then you can also start to see, what's the rest of my life looking like? How are my other symptoms?
Mm.
What else is going on in my body? So, okay, so the trials are focusing on pain reduction, um, some, quality of life forms that are standardized and the like. The trials focus a lot on fertility outcomes, and on they often will measure lesions of endometriosis. Okay, so that's all good and well, but I mean, what the patients are asking for is, or complaining of, or reporting is a longer list of symptoms that
Mm.
are all quite debilitating. I mean, chronic pain, of course, which is not only menstrual; it can be all the time.
Mm.
Dysmenorrhea, so that's period pain during around the cycle, pain with ovulation, dyspareunia, which is pain with intercourse, dyschezia, that means pain with bowel movements, urinary symptoms. This is very
Mm.
important because they can be very debilitating, and they can also lead to kidney damage, There are women who lose a kidney to endometriosis because the endometriosis blocks up the ureters and the
Mm.
urine flow is not good. So there's that. Then we have this chronic fatigue, which is also very debilitating, and digestive issues, bloating, like you can literally go from looking normal to looking like 9 months pregnant in no time at all. Um, and and yeah, food sensitivities, that kind of thing. And then, of course, the psychological impact of all of this, depression, anxiety, and the like. And then, I mean, there's another one which you will never see measured in a trial, and that is like lower back, hip, leg pain. Because
Interesting.
that would be also like there's certain jobs you cannot manage if you have constant lower back, hip, and leg pain, which can also feel like sciatica. It can be, in fact, endometriosis sciatica. So that's just like
Yeah.
some of the things that we are living with and wanting to have addressed. And yet the trial would have a much smaller, shorter list of outcomes.
Mm. And still, you being a patient advocate, have you been a part of actually a focus group to actually express and be vocal about these things? Like focus group, let's say on, let's say, any clinical trial design, or have you seen other colleagues of yours in the same space being asked about this?
I've been involved in some focus groups and I've taken part in some surveys and the like. I've seen work that's been done that I wasn't necessarily involved in, and good work. I mean, like the James Lind Alliance held in 2016 held a priority setting partnership on endometriosis. It's quite an interesting one because they they put out a call for patients and carers and the like to come forward with questions. They collected 4,800 questions from 2,000 participants, and then they sorted them into, they did their methodology with that. And what I found quite interesting was to look in the out of scope section where they didn't fit under clear headings. I thought that's kind of like where the clues are, where the patients are asking quite interesting questions and they themselves are trying to join the dots between our disease and other comorbidities or other
Mm.
similar type of conditions, or yeah, bringing up symptoms that don't appear in the typical trial outcomes.
So even when, let's say, these different side effects and like these different challenges of the disease are being expressed, that doesn't mean that this will be taken into consideration in the clinical trials. I wonder if you, I mean, at least that's how I understand what you're saying, which maybe there is a reason for that, maybe it doesn't. Like, to me, it doesn't make a lot of sense, but I'm pretty sure there is a logical explanation. I wonder, Estelle, because you've seen quite a lot of clinical trials, and I wonder, can you give me an example if we go the black and white approach?
Mm,
Can you give me an example of let's say a horrible clinical trial that you think, how did they even came up with this, and
mm.
who would actually join such a clinical trial?
I can.
Yeah.
Yeah, I look, I don't know about every single trial that's out there, maybe there's
Yeah.
something amazing that I've missed, but there are a couple that I was looking at recently that I thought were quite kind of interesting, good. Yeah, the two extremes, let's say. Um, the good ones are looking at new approaches to the illness, new treatments that are not just plain old, estrogen suppression. Okay, so that's that I can talk a bit more about. But I mean, I did hear about one trial which I felt I was very concerned about, and it was looking at. I mean, the goal of the trial was to ascertain whether surgery is useful for patients. Okay.
Mm.
Um, and whether it improves the symptoms, quality of life. It was looking specifically at superficial peritoneal endometriosis, which is one type. And there were two control arms, which was surgery, real surgery,
Mm.
where the surgeons went in and removed superficial peritoneal endometriosis, and the other one where they did sham surgery.
Uh,
So they opened up the patients and
they
they
don't.
looked
Yeah.
and then they closed them up and they didn't tell them what happened. Okay, neither, right? So it was
Yeah.
blinded. And they were recruiting, 400 women for this trial. And when I saw that, I was just very, very disturbed by that for several reasons. First of all, surgery. We know surgery helps. I think we know that already, but it's got to be excellent surgery. So running 400 women through a trial where somebody opens them up, and this is not expert surgery. It's something else, and I don't think that is going to help those women necessarily. And I find that I just felt like deeply concerned about the whole aspect of informed consent for that. How can a woman really, really confirm that she's okay with that? Surgery is a very big psychological burden. There are
Mm.
risks. And we also know that repeat surgery can cause damage, causes adhesions, it causes scar tissue. There's risk of perforation of organs,
Mm.
unintentional. There's risk of sepsis. It's just like, I
Yeah.
just found that seriously problematic for me. Um, yeah, so that was one where I just thought this is really a problem. Um, and and they were also looking at a kind of relatively limited duration of following those patients. It was apparently for 12 months, which is,
Mm.
that's okay. At the same time, we also know that women often come back within a few years for repeat surgery because it wasn't done adequately, because there's disease regrowth, yeah, for various
Yeah.
reasons. They're just still in pain. So adding a sham surgery to that, I think it's just too much of a burden for patients.
And still, do you think there is enough data out there to know actually how surgery is currently, let's say, the traditional surgery, what we do today, for example, for
Hmm.
endometriosis, there is a plenty of data that can be used and replace this control arm with sham surgery.
I think there should be we shouldn't be comparing surgery with sham surgery. We should be
Mm.
comparing excellent surgery with something else, with
Yeah.
some other standard of care. But excellent surgery, not just surgery, because we've also in our community, we talk and we've all been through operations with doctors that
Mm.
don't have the expertise. They just don't have it. They are not trained in that. It's a very special skill set,
Mm.
and you will get a different also a different technique in terms of the type of surgery. That there's more or less two schools. The one is ablation, which is kind of like shaving off the surface of the endometriosis, let's say. And then the other one is excision, which is like rooting it out, going deep below the
Mm.
visual part and making sure that there's nothing left, there's no root left for it to regrow. And so the endometriosis lesion itself and the damaged tissue around is removed. And that excision is another skill set, and it's a very sought after. Those surgeons are highly in demand. So I also,
Mm.
in the back of my mind, I'm asking myself, are those really expert surgeons? Are they really taking
Yeah.
part in that trial? I
Mm.
have
So
my
actually,
doubts.
that's you're raising a very good question here because normally, like the so-called site feasibility, they will decide on who will be the investigators, but their profile, like which hospitals and so on and so forth. In this particular case, the patient community will be very sensitive. Actually, who will be these people who are actually performing the surgery? On the one
Hmm.
side, the whole sham surgery, if I understand correctly, is a it's a one big no-no. But even if we don't have the sham surgery, if we even discuss just the surgery part, also it should be with the relevant people, with the people who are experts in this field, because the downside of having not the right surgery is also quite big, and it's a huge again no to these
Yeah.
women to even go through that, which is, yeah, which is very interesting. Do you have the opposite example, Estelle? Do you have an example of a clinical trial that actually looks quite promising, quite attractive for such patients. I'd love to see if we are to compare.
Yeah. There are two that I saw that I thought looked quite promising because they're looking at new treatments that are not just, hormone suppression. And the one is an enzyme. I'm not going to mention the
Yeah.
names, but the one is an enzyme which is looking at tackling the sites of the lesions. So it's going straight to the lesions, apparently, and it's not having a broad systemic effect on the hormone system. Let's put it that way. And so that sounds kind of interesting to me. And that treatment should be looking also at inflammation at
Mm,
those sites, which is good because, well, in fact, there's the endometriosis lesion, but the whole area around it becomes inflamed. And then there's systemic inflammation. So that to me sounded like interesting, and it's a new treatment. It's,
it's a
if I
new
understand
approach.
correctly, it's something new,
Mhm.
and that's what patients have been saying. Like, please look at the mechanism of inflammation. Please look at what's happening in those lesions, and how
Mm,
those lesions can be, stopped from that what they do. So that's the one thing. At the same time, and this actually applies to all trials. The inclusion exclusion criteria are, I think, because of the definition of the disease as a menstrual disease, and that's one symptom that you can track. The inclusion criteria are, women of a certain age, and they must have all their like reproductive plumbing in place. Okay, so they
mhm.
need to have the uterus, they need to have their ovaries, etc. So I can understand that that makes it easier to do the research, but that's like saying only those patients have the disease, which is not the case. If I've had those parts of me removed in standard of care, let's say,
Yeah,
I still have this disease because it's in my genetics. It's a
yeah.
systemic disease, it's a body-wide disease. So I would like to see, for example, is something like this going to help with body other organ inflammation or other aspects of the disease? That's a kind of an interesting point.
Let me elaborate on that. I want to understand actually what you're saying here. Um, is actually the challenge here that if the clinical trial is doing this like trial with women that are different than you, then you will be less likely to believe in the treatment like positives, the treatment promises, or is it that you think that there should be more a variety and diverse type of population that are testing this out, not for the sake of the treatment being just to be open and be more accessible, these clinical trials.
Yes, I mean, to the latter, yes, it needs to reach a wider. These trials need to reach a wider range of patients because we still have symptoms even if we don't have our
Yeah.
reproductive organs. So let's say that woman whose cry for help I read, she's most of her plumbing is gone, let's say, but she's still suffering endometriosis in her intestines, so she had surgery for that. So she's clearly living with active disease, and
Mm.
she's still suffering most of the symptoms. She doesn't have a period anymore, okay, but like a lot of the other things are still active in her disease. So why can she not be part of a trial that is reducing inflammation and lesions and that kind of thing? Like,
Mm.
it could be really useful for
Yeah.
her. You see?
Yeah, I get it. Still, at the same time, I'm also trying to like see the other perspective, where, for example, what clinical trials are hypotheses, and you need very
Mm,
specific data to justify this hypothesis and say I was right or I was wrong. So the idea at the end of the day is to prove a certain hypothesis and then go to the wider market where
mm-hmm.
you feel way more secure that you had some good positive results with this narrow group of people, and now you can test that out with in the real world settings where, for example, this lady can also have access to that. I
Mm,
get what you're saying.
yeah,
I'm not a biostatistician here, so probably I don't know what
yeah.
are the implications of adding more diverse group of people, I also agree with you. I mean, if you ask me, I'm also very much for more people to have accessibility to clinical trials.
Mm.
Then again, sometimes science has its logical explanation.
Yeah,
Why
yeah,
not? Like science, statistics, like
yeah.
statistics in general. But yeah, I completely understand. I wonder, actually, let me go back to this clinical trial
Mm.
that you said is actually more promising, let's say
Mm-hmm.
more attractive. You mentioned at the very beginning that one of the things that you don't like in clinical trials is that they don't necessarily tackle the outcomes that the patient actually is expecting to
Mm.
find. So in this clinical trial, do they actually tackle slightly different side effects, or not side effects, but let's say symptoms, and are the outcomes more aligned with the patient's expectations? Or you wouldn't say that is the case?
I don't know enough about it to say for certain, but it looks to me like the outcomes are pretty much the same. They're just trying a different treatment.
Got it. So the new treatment approach is actually the thing that makes it really special, like for you in this case.
Yeah, yeah.
Yeah, interesting. And still, um, if you were to imagine the ideal clinical trial, what would that be? How would
Hmm.
it look like? How would it sound?
Um, well, there would be a whole different set of outcomes. I understand that to compare one trial to another, you want to have the usual ones, but it would be great to have patient-reported outcomes. It would be great to have that longer list of symptoms that I'm talking about.
Hmm.
It would be great to have other the patients in there who are, say, for example, patients who are in menopause, they're usually
Hmm.
excluded because there's the assumption that, well, you don't have, much estrogen going on, so there's no disease growth. But we know that's not true for
Hmm.
some patients. So that would be, a subgroup. Um, Patients who, like this woman, she's got no more
Yeah.
uterus, cervix, whatever, um, but she's still got disease in other organs. That would be
Hmm.
interesting to know how are those patients affected by these treatments. Because ultimately, what we want is a treatment that will help those patients who are in their sort of reproductive years, to call it that, and the you know the ones who are supposedly past that, because we are still living with a chronic incurable disease with
Hmm.
lifelong effects. So it would be great if we were somehow able to be included in studies,
Yeah.
and for the follow up to be longer, to
Hmm.
look at some years down the line. I saw, and I was to go back to the what I said about the James Lind Alliance. I pulled out a couple of things from the out of scope category because I thought, let's see like where the clues are, and um I mean, there was like, what is the difference between endometriosis and cancer? Good question, huh? Because it behaves like a cancer, but it's not. So, what is really the difference? There could be something very interesting for researchers to
Hmm.
explore. Neuropathy and endometriosis, that's another whole like angle, is how do nerves transmit pain? Because we also know that sometimes the site of the endometriosis can be gone, but the pain message is still there. So how does that
Hmm.
work, right? How does then there was one who says, how does endo have such an effect on bladder issues that we spoke about earlier?
Yeah.
Because patients, I mean, that can be horrible to live with, but also you can lose a kidney. That's no joke.
Yeah.
So so there's something that needs to be really addressed that's kind of overlooked. Somebody else says, do you have it from birth? We don't really know why you get endometriosis. There's still like the very
Yeah.
basics
Like the
of the
basics.
disease. We don't
Hmm.
know the answers to that. Then somebody else says, are there other diseases like Lyme disease? Are they related to endometriosis? How is our disease related to other autoimmune diseases? It's not really an autoimmune disease, but it looks a lot like it. So what's the relationship? You
Yeah.
know. Then somebody else says, what role does the immune system, natural killer cells, play in relation to recurrent miscarriage even after egg donation in endometriosis patients. We don't know, we don't fully understand why patients with endometriosis have such a problem getting pregnant, embryo implantation, keeping the baby to full term,
Mm,
having a good, adequate birth weight for the baby. There's all of these other problems that are also need to be assessed. So that's around. I mean, I added more to the original question, which what would be an ideal trial. I mean, another consideration would be, like for any trial, a setting and facilitation and support that enables the participants to take part, to stay engaged, and that for all participants is things like, support with your transport costs. Because these are women assigned female at birth, a lot of them will, of course, be doing the lion's share of unpaid work at home,
mm,
childcare and pet care and parent care and that kind of thing. So every hour away from that is important time lost. So what about like vouchers to get a babysitter when you're going for your
mm,
on-site assessments, that kind of thing. So there's that whole area in which trials can be made more participant friendly.
Interesting. If I'm to summarize, because we can go on like this
Mm,
conversation forever,
mm,
I love what you said that in general, in every single disease, we need to go back to basics and understand where this is coming from. Like, that's the thing with every single patient advocate that I'm speaking to, they all say, well, one of the things is we don't know where this is coming from. And I guess, I mean, it's very complicated. I'm pretty sure that we all want to know that. But how much time do you actually spend on this rather than serving side effects or let's say symptoms? Side effects, not
mm,
but like
mm,
symptoms. And I kind of get the feeling that most people like you and like the other patient advocates that I interview, they all say that they have this feeling that research tackles the symptoms and not actually what's causing it, and therefore coming up with not new treatments that
mm,
tackle the cause rather than try to help you with some of the symptoms and not all.
mm,
But if I'm to summarize, what will make research way more attractive is besides being focused on this, going back to basic principles, also to know that you will be taken care by the experts who actually
mm,
understand this disease, especially in endometriosis,
mm,
like we discussed. These are rare people, but they really are specialists, and there is
mm.
for a reason that
Mhm.
they are so like needed. Then also being followed up for longer because
Mm,
this disease kind of acts as an autoimmune disease. So having an improvement for a certain period of time is not a guarantee that you are actually cured, and that will never go back. One thing that you mentioned, which is, I guess, it's the must have, is just tackle the treatment from a new angle. Try something different than hormones or surgery because people are not happy anymore today. So, what else can we try and tackle? And people will be more willing to give it a try. And
mhm,
then the last thing that you mentioned is also quite important, provide the necessary support. Because, like you said, these are like women that need to work, have kids, they have their own universes, so also
mhm,
we need this financial and not only type of support to be able
mm.
to participate in the clinical trial. Did I miss anything, Estelle?
I don't think so. I think we covered it well. Yeah, yeah.
Thank you so much for providing this perspective. I hope that in a year or 2 years, let's be a little bit more realistic, not so optimistic, we'll have another conversation and we will be discussing completely different type of
Yeah.
research targeting like endometriosis
Mhm.
differently. I
Maybe
hope that
precision medicine. I think that
yes,
could be
yes.
amazing and so perfect for endometriosis.
But I would also say precision medicine, starting with precision diagnostic, because you were right
Yeah.
at the very beginning. Like
Mhm.
diagnosis takes for like so much time. So maybe, hopefully, we'll get to diagnosis much quicker,
Yeah,
and
yeah.
that will help us to actually understand the disease much better and so on and so forth. It's like a
Yes.
snowball effect. So let's hope that we'll have better news next time. And thank you so much for sharing these insights because they're not just relevant for endometriosis,
Mm.
they're relevant across the board,
Yeah, for
unfortunately.
many chronic conditions. I agree.
Yeah.
Yeah, yeah. Thanks for having me, Maya. It's been a great pleasure.
Same here, Estelle. Thank you.